Well, thank you everyone for attending today's event, A Tale of Two Epidemics, a virtual panel discussion on AIDS, COVID-19, and the lived experiences of South Asian Americans. This event is a culmination of a 9-month fellowship project I have been working on to create a new archival collection and document the lived experiences of South Asian Americans during the early years of the AIDS crisis in the United States. My oral history project, Excerpts from an Epidemic, was inspired by my background in global health and my interest in public health history and queer South Asian history. The timing of this event is coincidental given that June 2021 marks 40 years since the first documented cases of AIDS were officially reported in the CDC MMWR. June is also lesbian, gay, bisexual, transgender, and queer LGBTQ+ Pride Month, celebrated in honor of the 1969 Stonewall Uprising in New York City, which was a tipping point for the gay liberation movement in the United States. To my fellow queer brothers and sisters and to the allies in attendance, thank you for being here. We live and exist in a chaotic world, grappling with a once-in-a-generation global public health emergency. COVID-19 has revealed a level of vulnerability across our society that has existed for decades, with marginalized populations continuing to bear the disproportionate burden of disease across the country. As we try to make sense of the new world we live in, it's hard not to see echoes of another epidemic, AIDS, that started only a few decades ago, and unless we have forgotten, continues to exist and claim the lives of vulnerable populations in the US and around the globe. There is much to say about the similarities and differences between both epidemics, but one of my goals of my fellowship project was to identify lessons from the AIDS epidemic and think about how we might apply those lessons to addressing challenges within the South Asian American community today. My oral history project primarily focused on capturing and preserving stories from the 1980s, 1990s, and early 2000s. So I wanted to use this event as an opportunity to bring my fellowship project into today's climate with this panel discussion. Before I introduce today's distinguished guest speakers, I would like to invite Samit Malik, the Executive Director of SAADA, to say a few words about the organization and the fellowship program. Samit?
Nikhil, thank you so much. It's so wonderful to see all of you here today. As Nikhil mentioned, it's not lost on us that it's a weekend, Saturday, and so we're so grateful to you for being here with us. As Nikhil mentioned, my name is Samit Malik. I'm the co-founder and executive director of SAADA. SAADA is a storytelling organization that works to create a more just and inclusive future by documenting, preserving, and sharing stories from our community, from the South Asian American community. When we started SAADA in 2008, so almost 13 years ago, we did so recognizing that there were no other organizations working systematically to collect and share stories from the South Asian American community, and fearing not only that our community stories weren't being told, but moreover that they were being lost. Nikhil's project and this event today is part of SAADA's Archival Creators Fellowship Program, which is made possible with a grant from the Andrew W. Mellon Foundation. In this program, SAADA supports fellows from groups that have been historically marginalized and excluded from dominant narratives about what it means to be South Asian American to share their own stories. This fellowship and the kinds of stories that it uncovers are, for me personally, some of the most meaningful work that SAADA has been able to be part of. And it's also exactly why we started this organization 13 years ago, to ensure that we create space in the South Asian American story for all of our experiences. It's been such an honor, truly, Nikhil, to work with you over these last 9 months and to witness the energy, the creativity, and the thoughtfulness that you've brought to this project. And I'm grateful to him, and I'm grateful to all of our panelists today and to all of you for being here today, for allowing SAADA to be part of your story. So you can learn more about our work as an organization on our website. The URL is saada.org, saada.org. And you can learn more about the fellowship program that Nikhil is part of at saada.org/ACFP for Archival Creators Fellowship Program. We're going to have our next open call for fellows in July, so next month. And so I hope that some of you will apply yourselves or share with others in your networks you think may be interested. And I also wanted to end by just sharing this really amazing for us victory that we'll be sharing next month, and July 8th is an event celebrating the launch of Our Stories, which is SAADA's new book that is for high school and college age readers. And so if you go to our website, again, saada.org, you can sign up for the event and learn more about this book project there. Our goal is to have this book in school libraries and in public libraries across the country, really thinking about the kinds of resources that I certainly didn't have growing up in Michigan in the 1980s, and wanting to ensure that the next generation of South Asian Americans has access to those resources. Just one quick actual logistical note in case it hasn't been mentioned yet. And I want to introduce my colleague Mariam, who is also on your screen. So anyone who needs live transcription, that's enabled. And Mariam, do you mind just dropping in the chat that information as well? You can enable live transcription by clicking on the option on the bottom of your screen. Nikhil, thank you.
Excellent. Well, now it is my honor to introduce our distinguished speakers for today's virtual panel event. I'll start off with, we have Aparna Bhattacharya, is a passionate advocate for immigrant survivors of family and sexual violence and ensuring they have access to safety, justice, and healing. As the executive director of Raksha in Atlanta, Georgia since 1998, Aparna has worked to ensure that attorneys, law enforcement, and service providers are culturally competent to serve immigrant survivors. She served as founding task force member and board secretary for the International Women's House and is a founding member of Tapestry, the immigrant and refugee organization that addresses domestic violence and human trafficking. She was a White House champion of change in May 2013 with a number of other Asian American women leaders, and she was named Georgia Asian Times as one of the 25 most influential Asian Americans in Georgia in July 2013. Aparna self-identifies as she, her. Next, we have Debenha Dasgupta, is an assistant professor of feminist studies at UCSB. Debanuj's research and teaching focuses on radicalized regulation of space, immigration detention, queer migrations, and the global governance of migration, sexuality, and HIV. Debanuj is the board co-chair of the Center for Lesbian, Gay, Bisexual, and Transgender Studies, CLAGS, at the City University of New York, the nation's first university-based LGBT research think tank. Debanuj self-identifies as Koti or genderqueer. Next, we have Kenrick Ross, is the executive director of the National Queer Asian Pacific Islander Alliance in CAPIA, a federation of 60+ LGBTQ+ API organizations across the United States. Over the past 15 years, he has held senior management roles in sectors as diverse as education, community health, civic engagement, and equitable entrepreneurship. Kenrick has made 2 short films, spoken and presented at 20+ conferences, and served on a dozen boards. He's also a fierce advocate for LGBTQ inclusive sports, especially all things tennis. He was born in Guyana, raised in the New York City area, and currently lives with his partner in New Jersey. Kenrick self-identifies as he, him. And lastly, but not leastly, we have Dr. Monica Gandhi. She's an infectious disease doctor, professor of medicine, and associate chief in the Division of HIV, Infectious Diseases, and Global Medicine at the University of California, San Francisco. She's also the director of the UCSF Center for AIDS Research and the medical director of the HIV clinic, Ward 86 at San Francisco General Hospital. Her research focuses on HIV and women and adherence measurement in HIV treatment and prevention, and most recently on how to mitigate the COVID-19 pandemic. Monica self-identifies as she, her. So thank you very much to our 4 panelists. I am so incredibly grateful for your participation this afternoon, and I'm very excited to chat with y'all and just pick your brains and hear some stories. And I want this to be somewhat of an informal conversation. So I definitely have some questions that I am directing towards each of you, but if there's anything that you would like to respond around a specific question that somebody else says, please feel free to jump in and include your thoughts. So I know I asked this to everyone in the chat, but I think it would also be a good idea to sort of have you share some stories to begin with. I like this question. It was also the first question of my oral history interview, which is, what is your earliest memory related to AIDS and or HIV? And what was your first impression of the disease? So I'll go ahead and start with Aparna.
So the first memory and then the first impression?
Yes.
Okay. You know, I was just thinking about the AIDS quilt, but I also grew up, I mean, I was a teenager in the 80s, so I recall all the safe sex conversations around HIV and AIDS. But of course, you know, growing up in the 80s, there was a lot of stigma, and of course, it was always focused on, you know, the LGBTQ community as opposed to impacting folks who were straight. So that's my memory of HIV and AIDS. But then I also remember all the community mobilizing around it and coming together, from the concerts and to the quilts, and a lot of advocacy is what I also recall about HIV and AIDS.
Great, thank you for sharing. We'll have Debanuj.
Thanks. My first memory of HIV, I was growing up in India and I immigrated to the US when I was 23. But so I first learned about HIV and AIDS in India, and I was in 8th grade. And I remember being in the Calcutta Book Fair. And at that time, AIDS was being called by different names: HTLV3, gay-related immigration, immune disorder, GRID. So there was a book about AIDS and GRID, and I immediately wanted to read about it because I was looking for anything gay back then. I was sort of figuring out my sexuality. And what it did for me was that I wanted to learn more about HIV and AIDS. What it did for me, it made that connection between being queer, gay at that time was the term in India, and AIDS, and it introduced a fear about my body and sexuality from the get-go. So I mean, hindsight, I think my coming out got really complicated with the fear and stigma around being gay and AIDS. So that was my first impression of HIV and AIDS. And as you know, Nikhil, and as many here know, I founded the first HIV prevention program for gay men, men who have sex with men in Kolkata in 1994. So, that fear and that sort of lack of any support or knowledge around HIV and AIDS kind of propelled me as a youth leader to continue to seek out information about HIV and AIDS, how to protect myself and others. And sort of, part of the long story is I ended up founding the NAS Kolkata project. Thank you.
Great. Thank you so much for sharing, and we'll definitely dive into some of those experiences a little bit later on the panel. I'll have Kenrick go next.
So mine was a little bit more personal. I was probably 13, living in an apartment building in Jersey City, and the person downstairs, who's a friend of the family, her grandson was gay, and he was HIV positive. And the way we found out, and my family found out, was because there was also a Guyanese nurse at the hospital who found out his diagnosis and told everybody in the community. And yeah, I was probably 13, 14. And I remember I saw him once, and I still remember he was, a very good looking late 20s. And about 2 years later, he died. And that was my first impression. And my mother said to me, this comes from masturbation, right? It's like I'd already done sex ed in school, so I knew that was not true. But this was the level of lack of understanding, fear, and made up stuff in our communities at that time. And I remember that woman almost curtailed herself from the community, from looking people in the eye, because not only was she marked by the fact that her grandson was gay, but he had died of this thing that people thought of this thing. So that's my first memory personally of AIDS or HIV. And I think my first impression, so I read a lot more about being gay than before I did things being gay. So I read a lot of gay literature, 17, 18, 19, and that intersected with what we now consider to be AIDS literature. So it was an entire generation genre of books that made you very fearful of what it was. And this was before the time, this was around the time of AZT, I think. So that's how far back it goes. So I discovered it, my impressions of it was a lot of fear. But as soon as I, came out and met people, there was a lack of fear. Like, I educated myself. I saw how important it was to be part of community. And so that quickly fell away.
Great, thank you so much for sharing. And finally, we'll turn it over to Monica.
Yes, so thanks for having me. So my first impression is that I grew up in Utah. I was an Indian American growing up in Utah, which was a different place to grow up. And I had a friend in high school who came out as gay, and after that, his parents kicked him out of the house. And it was the middle of winter, and it was really cold. And it really actually set me on a path to work on HIV/AIDS. It was truly that event, and also the experience of being brown in a relatively white state, and a state that had a specific religion, that set me off into wanting to go into medicine and actually fundamentally work on HIV. It was my only goal. So I went to Harvard for medical school, and at that time, this idea of combination therapy was just starting. That was 1991. And it was amazing that we had starting to have medications here, and there were no medications anywhere else. And then in 1996, I came to UCSF for my residency, and have stayed here since, because it was the epicenter of HIV in the 80s. And so it was the only reason I came here was HIV medicine. And I did an infectious disease fellowship here. And at that time, by the time I started my internship, we were the Lazarus effect. We were starting to see people do so well from these HIV medications. And yet I'd been to India many times. I'd been to Sub-Saharan Africa, and there was clearly no dissemination of these life-saving medications worldwide. And it was sort of profound to see that incredible disparity that I had already noted and had been of interest to me and importance to me growing up and going to India as I was growing up. So then when there was more access worldwide, I now am working on COVID, or at least I'm an infectious disease doctor, so I have to think about COVID, and I keep on being completely profoundly struck by the fact that we have vaccines here and we don't have vaccine access elsewhere, or at least only 0.3% of vaccine doses with COVID have been disseminated to low-income countries. So everything is feeling very familiar and very painful, actually, with that interplay. And I know that's what this panel is about. So that's my earliest memory in my history.
Great, thank you so much for sharing. And it definitely leads into my next question, which I'll have you start, but I just wanted to say thank you everyone for sharing your stories. And the reason why I like to start with this question is because I think there are a lot of different ways that we engage with the idea of HIV/AIDS in our society. Some of us have very personal connections, some of us have impersonal connections, but sort of know about it as an epidemic or a pandemic that still exists in today's world. And I think it's important to sort of ground ourselves in sort of how do different people think about the disease as a way to sort of jump into our conversation today. So Monica, you definitely spoke a little bit about sort of what inspired you to work in the HIV/AIDS space. And you talked a little bit about your history of working in the HIV/AIDS space, but perhaps since we have 4 different panelists who sort of work and engage with HIV differently, I asked you to be on the panel given your work as sort of a public health practitioner and then of course also as a clinician. So can you talk a little bit more specifically about what does your engagement with HIV and or AIDS look like today? How do you engage with those issues in your work today?
Yes, so actually, except for the last 15 months where I've been thinking about COVID some, it is really my entire life actually is to engage and think about HIV, meaning I have 2 really large roles at the university that are both in the clinical world and the research world, that's HIV. One of them is that I am the medical director of Ward 86, which is an HIV clinic that was formed in January 1983. So we do think it's the oldest HIV clinic in the country. And I'm both a doctor for people living with HIV, but also have a role in trying to help the clinic do better. And what we've been working on lately actually is the impact of homelessness in our city, that we have a lot of homelessness in San Francisco, and the impact of homelessness on HIV outcomes, which, as you imagine, is terrible. There's a lot of low rates of virologic suppression in people who are homeless and living with HIV. And then the other aspect that really brings me into contact then is by being a doctor of people who live with HIV, and that's the only type of patient I see in the outpatient setting is people living with HIV. I'm very aware of the stigma that is ongoing, still there, completely present in people's new diagnoses, ongoing diagnoses, what it felt like this year having the COVID pandemic, being told to stay away from other people, being told that you're a vector if you go out and see people. It was really profoundly hard for people who live with HIV to have this concept that that you are a disease vector, which is essentially how we presented COVID risk to people. And so it really struck me that we didn't use harm reduction messaging in COVID, even though, and it was long earned in HIV to start using harm reduction messaging. And then the second role is that I'm the director of the Center for AIDS Research. So I think about HIV research in different topics. And really the topic that I'm most interested in is this concept that we have these great drugs, and yet it is still the social determinants of health that make it so difficult for some people to access those great drugs and take them, and their substance use, mental illness, homelessness, access, stigma. And I'm interested in those problems, that it isn't just about providing a vaccine or providing it for COVID or providing a medication option, but it's about everything that's so complex in people's lives that interplay with their ability to take medications.
And this idea of sort of social determinants of health will definitely come up again later on in our conversation when we talk about COVID-19, because I think a lot of the structural issues that were drivers of are drivers of the HIV epidemic, I think we are seeing that play out again with COVID-19 today. So
yes.
We'll definitely talk about that again at another point in this conversation. So to Kenrick, since you serve as the executive director of Incapia, which is focused on advocating for queer Asian Americans and Pacific Islanders, we know that thankfully that HIV is not a gay specific disease. However, it is primarily concentrated in queer populations, particularly here in the United States. So how do you, in your work, working with the AAPI community, the queer AAPI community, how do you engage with HIV/AIDS in your work?
I think to start with, we are trying to put a bigger emphasis on engaging in that work. My first job was in Whitman Walker Health, which was a large HIV organization in DC. I was in another community-based organization. I've spent a lot of time primarily in Black queer spaces. So HIV has always been a priority topic, not just for sociological or academic research, but the lived experiences of people, friends, partners, community. So shifting into this role at Incapia, I'm a little amazed and troubled how limited the conversation is today on HIV in queer and trans API communities, especially given the history that many of our queer and trans API organizations started out in response to HIV/AIDS and the lack of spaces and the lack of outreach materials. And those organizations are still around today, and they're still part of Incapia. They are foundational members of our movement. But there is this idea that, the API community in general is post-HIV in a way. And I saw that a little bit reflected with COVID, that South Asians had done so well in the United States in terms of vaccinations and maintaining certain social determinants, but India had done so badly. And it reflected in the same way of many conversations I've seen with HIV, that the epidemic rages in the Caribbean, in India, but the conversation is much more limited when it comes to the United States. So one, for me, it's, yes, I understand statistics. I also understand that disaggregation of data is so very important, because we see this, pile of data comes along with API communities are not as impacted, certainly not as impacted by but compared to Latinx and Black communities. But we also know that the rate of testing is ridiculously low, and the rate of managed care is ridiculously low. So I approach this, and then Copy is approaching this, that one, we have to have this conversation because people need to be part of a conversation, one, in terms of testing, prevention. But can you imagine in a community which does not really see HIV, when you're HIV positive like me, how erased you are from that conversation? So we have to make sure that from a clinical point of view, we are, again, addressing HIV, even if it's not topic number 1 or number 2, but it exists, and to make sure that we're not erasing the people that not just need help or access to medication, insurance, but also the community, and to be seen.
Great, thank you so much for sharing, Kenrick. So to Aparna, as the executive director of Raksha, an advocacy organization addressing domestic violence in the South Asian community, how do you engage with HIV/AIDS in your work? And maybe perhaps for those in the audience who are maybe a little bit unfamiliar about the intersection of domestic violence and HIV/AIDS, perhaps you could talk about how those issues overlap.
Yeah. So I don't think we ever intended on addressing HIV or AIDS. And one of the unique things about Raksha is we're the only South Asian social service kind of advocacy organization that's not a professional-based organization in Georgia. So when we started, Raksha was actually supposed to be kind of a catch-all organization for South Asians, and I think our tagline was for South Asians in distress. And so we were it when it came to a lot of the social services, and so we kind of had to flex. We didn't really intend to just be a domestic violence organization, even though that is predominantly what our strength is in here in Georgia. And Nikhil, you interviewed a good friend of ours who is also a volunteer and a former board chair of Raksha named Khurram Hassan. And that's where I started really first hearing about HIV and AIDS work in the community. And, it was just so cool to see a South Asian doing progressive work. And so I was so fangirling over Khurram when I met him, because I was like, somebody else who wants to make social change and do work in the community and isn't following that traditional path that we're told we need to do. But I recall Khurram got in touch with some community members that needed support. And that is where Raksha got involved with a few individuals who are HIV positive, and trying to just build community and build support around them. But many of them had become friends of ours and became part of our lives. And that's kind of how we got engaged in doing HIV awareness work, because we wanted to break that isolation for individuals who needed community, right? And here we wanted to be community for those individuals. But then later on in the work, we had heard stories of other STDs being spread, and we were trying to do prevention work just for folks to know about prevention, or even have little packets with condoms and messages around safety, and try to have it at the professional events. And I remember the blowback we got for doing that, even though we knew that friends of ours were getting STDs and there was unprotected sex occurring. But the community, again, we don't want to talk about it. We don't want to talk about domestic violence. That's something we don't ever want to talk about. And we feel like we're immune to it because we're the privileged few that came to the United States. It's the same thing about HIV and STDs and any kind of even mental illness. We don't want to talk about it because we think we're privileged. And I think that's where Raksha's role is breaking down those myths and creating community and talking about the things that we don't normally talk about is really important. And it's become even more important because we've lost friends, volunteers, and community members that we love as a result of HIV. So for us, it was something that we felt very strongly about, and always looked at the intersections. And I think when we talk about domestic violence, it's also about someone, control of someone's birth control or access to protection, individuals being able to even ask to use it. I remember we were trying to work with an agency around, you know, uh, talking about empowerment for women to ask for birth control. And some of the things that we brought up were like, there's no way that women in our community could ask for birth control without being questioned and without it being a very dangerous situation. One of the things, and one of the things that why HIV and AIDS is also important is that when Raksha first started, many of the volunteers came from Tricone, Atlanta to support Raksha. And for that reason, Raksha and Tricone had such an allyship that we felt like we really needed to show up and be there, because so many of the Tricone volunteers took Raksha into their heart and became a big part of it. So that's another reason why we continue to look at the intersections of not just HIV and AIDS, but also all the other intersections in our community and being allies to the LGBTQ community.
Great. And just a note for everybody in the audience, if you're not aware of what Tricone is the oldest South Asian queer network in the United States. It started in San Francisco and the Bay Area and spawned chapters across the country. There are also similar organizations with different acronyms, such as SAADA in New York and Kush in DC, but all of them sort of originated from Tricone and a magazine that they produced that really was distributed not just across queer South Asians in America, but also there was reach in Canada, in the UK, and even all the way to India. So Tricone is a foundational organization when it comes to some of the queer work in the South Asian community, and there's definitely a big overlap between the work that Tricone was doing and something that I'm exploring in my project is sort of ways that Tricone showed up for issues around HIV/AIDS, but also ways that Tricone did not, and reasons for that at sort of the organizational, but also at the individual level. So great. And then lastly, to Debanuj, as a feminist scholar who has written extensively about queer theory and queer migration, and you've talked a little bit about how you started one of the first HIV/AIDS organizations for men who have sex with men in Kolkata. In terms of the work that you're doing today, how do you engage with HIV and/or AIDS in your work?
Thanks, Nikhil. Well, my work today is kind of boring. It's academic, it's archival, so I'm actually, right now my work is around sort of rewriting the history of the HIV ban on immigration, and sort of the contemporaneity of some of what each of you have brought up about the LGBTQ movement, South Asian sort of, for lack of a better word, civil rights, or South Asian community organizing projects, right? And so I'm kind of seeing how these kind of parallels. So in my recent work, I write about how the HIV ban on immigration, which is not a new ban on immigration related to diseases. I just want to say that up front. I mean, from the Chinese Exclusion Act, which was passed in the US in 1882, to a ban on tuberculosis, there has been major, disease and public health related immigration bans in this country based on fear and contagious diseases, right? So right now I'm looking at the history of the ban. In 1987, I'm just going to briefly narrate the history of the ban and kind of sort of point out the connections with South Asian communities. So in 1987, Health and Human Services introduced a mandatory testing for all foreigners seeking entry to the United States for HIV. And at that time, very little information, as all of us know, was available. Scientific information was still coming out about HIV and AIDS. In November 1991, about 270 Haitians who were escaping the overthrowing of the military regime in Haiti were interdicted in water and 271 and taken into the Guantanamo Bay for indefinite detention, and majority of whom were forcefully tested and were found positive and were living under very inhumane conditions in Guantanamo Bay. So it kind of predates Guantanamo Bay and HIV, and detention predates the war on terror and sort of indefinite detention in Guantanamo Bay. And the Haitian Centers Council filed a lawsuit, and around the same time in 1991, and many of you were here, so big shout out to Radhika, as well as I see Shrithar and Surabhi. But in 1991, South Asian AIDS Action is formed. So it will be interesting to sort of bring out this contemporaneity in thinking, because both are happening around the same time. Haitian Centers Council won the lawsuit and were able to get the Haitian detainees into treatment in mainland United States. But by 1992, we see Senator Don Nichols of Oklahoma introduces the ban as a law and wants it to be written down into the INA, the Immigration and Naturalization Act. My work, so, when I came to the US in 1996, I think, I had done all this HIV/AIDS activism and, prevention work in Kolkata in India. And I came to the International AIDS Conference in Vancouver. Shrithar, if you remember, I met you there. So hello, Shrithar. And and I come to the US and I start working around LGBT and immigration and HIV/AIDS issue as a researcher. My first degree was in urban planning. But I lived as an undocumented person for about 8 years, because even though my immigration case went through, the ban was in existence and I couldn't naturalize my status under the ban. Ironically, I had a fellowship to work on the policy issue, sort of on LGBT immigration policy issues. In 2003, I was extremely ill and almost dying. I had PCP and I had KS. All of these at this point are treatable because of the DNA of the combination therapies, which I was afraid to access because of my HIV status. So now in my work, I mean, hop, skip, and jump, in 2008 onwards, I worked on the campaign to remove the US HIV ban on immigration. And when we were doing that work, we were told it's impossible. You're never going to get it removed under the George Bush era, right? But we sort of kept organizing. It was multi-coalitional. So we brought LGBTQ rights groups. We brought not only groups from the US, but groups who were impacted, like sex workers unions, scientists, HIV positive scientists who couldn't enter the United States if there was any AIDS-related work that was happening. Up until 2010, the ban got removed in 2010. Up until 2010, the International AIDS Society boycotted the United States for the HIV conferences, right? So I worked on the removal of the ban, and in my research now, I kind of recap that history. I've published a little bit about it, but more is upcoming. I'll just give you a short snippet. When we were working in 2008 and 9 to sort of attach the removal of the HIV ban on immigration to the Henry Hyde bill, which was the Presidential Emergency Fund for AIDS Relief, PEPFAR. So the way we were able to argue this is that, the fear at that time, we were able to prove HIV is not a contagious disease. And we were arguing that by not allowing HIV positive immigrants to legalize in the country, the US was losing in income and in taxes, right? Because the fear was the public health cost, the burden on the United States public health coffers for providing treatment to undocumented immigrants. So I worked with the Congressional Budget Office to calculate what would be the cost. And at that time, it seemed like assuming that every undocumented HIV positive immigrant would not be able to pay for their treatment, assuming that the cost would be $83 million. And unfortunately, during that time, as part of PEPFAR, Congress was actually going to increase $1 on every visa application to the United States, right? And that would bring in an additional $103 million of income to the United States. So this kind of very inhuman cost benefit analysis actually allowed us to push the removal of the HIV ban as a policy, right? In no way could we talk about the emotional impact of the ban. If the ban existed from 87 to up until 2010, you can only imagine huge amounts of South Asian populations were impacted by the ban, you know. So finally in 2010, we removed the ban, but, you know, I want to talk about one thing is that so much of HIV work, the stigma is wrapped up with respectability politics and like not wanting to talk about issues of sex work, not wanting to talk about pleasure, right? And like bodies and the rights of bodies to have different kinds of pleasure. What happened was when we were working to remove the ban, unfortunately, the ban on sex workers, HIV positive sex workers and injecting drug users remained, you know, and so it's this give and take of policy activism that breaks my heart. And I'm writing about it now. And in 2012, when the International AIDS Conference returned to the United States, there was a parallel AIDS conference of HIV, of sex workers and ID users and harm reduction activists in Kolkata. And I was able to legalize my status in 2011. So in 2012, I went to the International AIDS Conference in Kolkata, my home city, as a way of solidarity with sex workers.
Great. Thank you so much, Debanuj, for sharing your story and sharing some of that really important history that I think I'm definitely looking forward to it being preserved and captured. And we'll definitely touch upon some of this work later on in our conversation, because I think there are some definite parallels with some of the conversations we're having right now around sort of cross-border transmission of COVID-19 and like immigration and the Chinese travel ban and COVID-19 vaccination passport. So I think there's a lot to talk about when we get to the section on COVID-19. So I know that we've definitely spoken a little bit about sort of everybody's relationship with sort of the South Asian American community, but given that sort of my project is specifically about the lived experiences of South Asian Americans, not necessarily those who are HIV positive, but about us as a community and our relationship and how we engage with HIV/AIDS through our cultural lens. I sort of wanted to dive in a little bit deeper into some of our thoughts around the community specifically. So to Monica, as somebody who works directly in HIV/AIDS from more of a clinician and public health perspective, what do we know about HIV and/or AIDS within the South Asian American and/or the AAPI community in the United States?
You know, there isn't a clear working out of delineating two communities of API, Pacific Islanders and South Asians. So essentially of 40,000 people who were diagnosed with HIV 2 years ago, which is the last time that they've collected full data, 2018. 2% were in Asians, and it's just putting together that data that 2% is in Asians. So that is hard to tease out what that means. I mean, certainly it's important to know that people who don't seek out testing sometimes are those who are most stigmatized in their communities or most stigmatized in feeling that maybe they're not at risk or not even wanting to know. And so I think it's, you know, we supposedly took a routine-based approach to testing in 1996, but that really isn't being practiced, where you just say, make it totally routine. You know, this has been codified by insurance companies even, that everyone should be HIV tested at a certain point in their lives. But even at that point, there is this still risk-based testing approach. If we could make HIV testing more routine, it would not feel stigmatizing to get an HIV test. And so I don't know what that represents. That's just where we are in terms of the current status of the 40,000 new infections. And I am interested in working with groups like yours, I'm very interested in HIV testing, and also thinking about what we can do after this COVID year, or even longer of COVID than a year, because I think that new diagnoses came up. I think that new risks came up. It was a really lonely, hard year. And so I'm really interested in working with groups like yours about HIV testing.
Great, and thank you so much for that context. I think, again, we hear a lot about sort of the HIV crisis. We hear about it in sub-Saharan Africa and Southeast Asia. When we think about it in the United States, we primarily think about it among people of color, Black and Latinx, gay men, or trans populations. But being able to sort of think about, okay, well, what does it mean for our community of South Asians and Asian American Pacific Islanders? So I think understanding some of that epidemiology, I think, is an important place to start. So to Kenrick, given the work that you do with queer Asian American Pacific Islanders and any South Asian Americans within those communities, sort of what are some of the challenges to reaching queer South Asian Americans with information or service delivery around HIV/AIDS? And just something that I want to tack onto that question also is, given that you're someone from the Indo-Caribbean community, do you see the need for different approaches for subpopulations within the South Asian diasporic umbrella?
So I think I'm kind of at a loss for modules of how to address this going forward. I think there's a consequence to the relative success that we've had with the treatment of HIV, the normalization of the chronic nature of HIV in some ways, that the old modules don't work. And that's a great thing. Like, for example, I'm from the gay tennis world. All of our clubs came out of the pandemic, the epidemic, and all of our tournaments would raise money for AIDS charities. We have 75 tournaments in the world right now. Very few still raise money for AIDS charities, because the crisis is now around youth, for example, or transgender rights. So we raise money. So things change, and those modules have changed. So I think for Encapia and the communities that we work with, one is there isn't the conversations that used to happen before. HIV is not as present of mind anymore, in the same way that we no longer give out condoms at events or have safer sex messages wrapped into all of our events. That it has become less present of mind, but it has also become much more stigmatized. I am willing to say that there's a certain level of privilege that it doesn't impact us as much as it impacts other people. And the reverse of that is that we don't want to be associated with those people that it does impact. And I will go as far as to say there is a level of anti-Blackness in this. I've known people within Encapia that refer to Black people as Jamals. And it's tied to, those are the people with HIV. And I feel that we have categorized HIV into these discrete, vulnerable, marginalized populations of race and sex work and trans folks. And we know the statistics that for many people, they feel that they are not part of that group. So they don't need to be tested. They are not impacted by it. So I'm very much interested in new modules that promote testing. I would love for every Federation member to make sure that on May 19th, they're at least doing one type of programming across the country that focuses on testing, preventative PrEP, access, insurance navigation for these things, conversations, all those things, all those modules, we are very interested in in creating again. And I would love all kinds of input from everybody on this panel of how we do that, because we don't have those modules that worked so well in the past as they're not relevant anymore. I think for us at Encopia, because we are also working on policy, it is not just the clinical aspect and medical aspect, but how are we in solidarity with the communities that are more impacted? So for example, going forward, part of our commitment to Black lives and queer Black lives and Black trans and queer and trans Black lives is to talk about the decriminalization of HIV, for example, and the decriminalization of sex work. These are intersectional topics that at the same time that we want to increase the rates of testing within API communities and more conversations and innovative projects like this, to bring it in front of people to say, this is still relevant to you, even if you don't feel it is. We also want to make sure that we're working on issues that lift up all the communities in which we live. And that includes sex work, and that includes the decriminalization of HIV, which is criminalized in 32 states. So that's our approach. In terms of Indo-Caribbean communities, I think the more we disaggregate data, the more we disaggregate cultural competent programming, the better for us. So our approach is that we have to go from API to DESI, to the communities within, to the regions in the United States where they live, and how do we utilize existing Encopia groups that are trusted in those communities, the Salgas, the Kushes, the CEPs, the Tricones, the Samchas, to have those events and to carry those messages, and also how do we seed and facilitate newer modules, and people have other ideas for us. So the closer to the ground, the closer to the community, I think is the better for us.
Great, and I definitely invite everybody, not just the panelists, but also attendees, if you are interested in any of these topics and you have some ideas, we'll definitely be sharing some contact information for everyone. So feel free to reach out to Kenrick and the other panelists if you have any thoughts related to any of the work that you are doing that might be supportive of some of these initiatives. I want to build off of something that Kenrick mentioned around sort of the community coalition building with sort of the African-American community in the United States. And I'll turn this over to Debanuj. One could definitely describe racial injustice and police brutality as another epidemic that's facing our society on top of COVID-19 and on top of AIDS, HIV/AIDS. Not just Black Lives Matter, but also with the recent shootings in Atlanta of the Stop Asian American Hate. So as we think about health disparities of diseases such as AIDS and COVID, why should South Asian Americans care and be allies in these conversations?
Thanks, Nikhil, and it's so wonderful to hear this multiple perspectives. So, I want to talk about one other way I'm doing work around HIV currently, and that'll kind of answer your question, and I'll make some broad points quickly. So, I'm working on my book right now, which is about transgender detention politics and the trauma that transgender asylum seekers, refugee seekers experience once they are within the detention and deportation system, right? And one of the ways that the trans community experience trauma within the detention center is routine denial of HIV medication. So, some of the known cases of deaths, Roxana Hernandez very recently, or Victoria Arellano, these were cases of trans women who were shackled while in detention, asking for HIV medication and given like Tylenol, and like the nurses and the doctors, the detainees in the next cell would say, are saying that, the nurses and the doctors would say, you didn't think about anything when you were getting this disease. Why do you want medication for free, right? This level of inhumanity around the virus, and still the figure of the immigrant continues, right? And so, and I think if we flip our prevention and train and sort of care and think about who's the most marginalized, who has the least access to any form of testing, care, and vulnerability, I think we can lift up everybody, right? So, and immigration is a huge way, is a huge issue to South Asian communities, you know, and South Asian and Indo-Caribbean communities.
Oh, Debanuj, we lost you. Okay, well, hopefully Debanuj will come back. Aparna, did you?
I want to take this.
Oh, sorry, here we go. We're back.
Okay, can you hear me now?
Yes, we can hear you now. Great.
Sorry. I was saying I wanted to name one activist whose work gets on sort of not included in the South Asian HIV story is the story of Michelle Lopez. You know, Michelle Lopez is a New York-based, very, you know, big advocate for HIV/AIDS work, and she's an Indo-Trinidadian, you know, activist and of Trinidadian immigrant of Indian origin. And you know, she doesn't even get counted in within the API population, within the queer API narrative, but she has been on the boards of National you know, Association for People Living with AIDS. She's you know, a single mother who has raised an HIV positive child, you know, lived under the HIV ban. So I'm with Kenrick around, I mean, and she's more considered as an activist within Black African communities than within South Asian communities. So this proximity that us South Asians think that we have to whiteness has to be rethought. We really have to think ourselves in proximity with Black, African, Latinx communities. And I think that will really help create like radically different visions of South Asian health and justice, you know? And we have these connections already. I mean, when I just gave this interview earlier to this, and I'll stop after this, when the year I moved to New York, which was 2000, was the case of Amadou Diallo, you know, who was shot 41 times, I think 41 times by the NYPD, and the police officers were left scot-free. There was huge amount of organizing around Amadou Diallo's case, and South Asians Against Police Brutality was formed, you know, SAPBR. And I'm glad that we had that experience and that formation prior to 9/11, because it really allowed us to create, you know, and consciousness around police brutality. So I just want us to sort of rethink that around that.
I mean, one thing, if I could just add to that.
Yes.
No, it's not my
Yes.
turn.
No, absolutely. Go ahead.
It has to do with what you just said in terms of joint community, in the sense that I used to work on HIV in women a lot. And I was working in a city in which gay men had been the majority of the epidemic in San Francisco. And it was actually with that embracing that we're all in this together, that we're all, you know, your problem is my problem. Women living with HIV has solidarity with men living with HIV. It was when that embracing happened that things got done. I mean, it really was when everyone stormed together, the FDA, to advocate for release of the protease inhibitors, because we had enough information already, and that people didn't have access to them. Throwing blood on the FDA, you know, awnings as people should, wrapping Jesse Helms' house in a condom. Like these are all things that we did together once we recognized that we were all in solidarity. And so the same thing is true right now with the solidarity of what happened with COVID, of what happened with social determinants of health, what happens with, you know, being brown or Black in the United States. And if we could recognize that solidarity, we would actually move wonders in terms of HIV.
So I know that we are definitely running a little bit over time, but I do want to bring this conversation into the diseased elephant in the room, as I'll say, COVID-19, that we are all sort of living under its shadow. And definitely COVID-19 has definitely impacted the way that we work and the way that we engage with some of these issues. So as if it wasn't already hard enough to work on issues related to HIV/AIDS, now we have to deal with a new work environment and populations that are even more challenging to reach. So to Aparna, I think one of the pieces of news that we heard over the past year was sort of that there has been, with all of the lockdowns and the quarantines, we have seen an increase in domestic violence rates during this time of COVID-19. So I am curious to hear a little bit from you about sort of, from your perspective, what has been the impact of COVID-19 on your work in domestic violence, particularly within sort of South Asian communities?
It's quite complicated. You know, when we think about South Asians, I know we tend to think that we're privileged, but we have a lot of South Asians who are undocumented, who are waiting for immigration relief based on the abuse that they're dealing with or have experienced, and it makes them way more vulnerable. So if you're still living with the abuser, of course, I mean, everybody's mental health is even more vulnerable during this time. So violence is more likely to happen, and often there's less opportunities to reach out for help when someone is constantly at home. And I know that I've heard stories of people turning off access to cell phones because they're trying to save money. So depending on your income bracket, if you have less money, that can increase the stress, less access to medication, less access to all the things that you may need. And then for survivors who have left their abusive situations and are, again, you know, they may not be able to work. The increased victimization by landlords, by people that they may be staying with. A lot of the survivors we work with can't get, you know, leases in regular apartments because they can't afford it. Atlanta's becoming like New York. It's impossible to find affordable housing, and that makes them more vulnerable to other victimizations from landlords to other family members. We had people who couldn't even cook their own food in their apartment when they were trying to flee violence because the landlord was horrible. So it just aggravates everything, and it increases the risk and the danger for many survivors, and it's even harder to ask for help and get support. And then even if you do get out, there could be limits, or you have to stay in hotels, and there's so many barriers to getting help during this, you know, epidemic within another epidemic. So it's definitely increased the stress and made it more dangerous for many survivors. And we've had some domestic violence homicides that have occurred during the pandemic of, you know, people that, I know there was one in the New York, New Jersey area of a restaurateur. So it's a very dangerous time, and it's very stressful. And of course, nobody wants to talk about it. There's still so much shame and stigma around domestic violence as there is around HIV and getting the support that one needs.
So I'll toss this question to both Monica and to Kenrick. I think we definitely have a good sense of sort of the ways that COVID-19 has made all of our work more difficult, but I am curious to hear, have you found any opportunities in COVID-19? Have you been able to do any new innovative work that COVID-19 has allowed you to do in a way that maybe you weren't able to before, especially related to the HIV/AIDS work?
You know, for me, because I'm an infectious disease doctor, not just an HIV doctor, but I think of T cells all the time because HIV is a virus that and specifically infects CD4 cells. I have been thinking a lot about T cell immunity with COVID and why we are scaring people a lot about relying on antibodies and talking about Delta variants and antibodies going away and how strong T cell immunity is. So that's how I've been educating, and that's how HIV informed COVID for me. But the second one is harm reduction. We absolutely needed to work harder on keeping people safer during COVID, but we didn't do it in a harm reduction way. We didn't actually harm reduction. The entire point that we learned from HIV is to reduce the risk of an infection by acknowledging that people still have may be exposed to a pathogen. So you talk about, like you said, pleasure and sexual pleasure in the context of sex. and that's important. And then you don't just dental dam and put everyone like together, together as if oral sex is the same thing as higher risk as other types of sex. And we did that at the beginning of HIV. We like said everything is dangerous, stay away from each other, which is ridiculous. And instead then got into more nuanced messaging about what's safe and what's not safe or what's higher risk. And somehow with COVID, there was zero learning, it seemed to me, about harm reduction messaging from HIV. And instead we said, just stay at home. That's the only way to stay safe. We scared people to death. We didn't talk about mask distancing, ventilation, what you could do in a school or business. And then also we put essential workers out to the winds. Like we didn't think about, how important specific types of masks were. We didn't think about aerosolization and we didn't provide masks for essential workers and the types of masks that would have worked best to keep them safe. We just employed this like stay at home so that the rich people who did tech all got richer and like a lot of other people suffered and got infection. So I am not positive why we haven't learned about harm reduction messaging 40 years later for COVID from HIV, but HIV for me was the ultimate profound example of how important putting someone's real world needs are, including sex. Real world needs are when you advise about a pathogen. And so HIV is how I grew up and it's how I'm messaging about COVID, and I'm not agreeing with some of the messaging.
Thank you. Kenrick, do you have anything to add?
Sure. So in terms of opportunities, I think for Incapi and for a lot of our members, our connectivity to community actually grew virtually. So a lot of organizations had to pivot very quickly, but in doing so, and clearly there's a divide of privilege and access for people who had, broadband for me is a very important thing. It doesn't seem to be like a social justice issue, but it is, because for many people, the ability to go online, not just to study or to do school, but the fact that so many people were living in homophobic homes, had to return to homophobic homes. And we think of it as youth or college students who would come out and then had to go back in. But we also had grandparents who had to go back into homophobic homes to live with their children. So it spans the spectrum of, there was a lot of privilege of people who would go online, but for those people who went online, Incapi members were able to create a sense of community and connectivity across their communities, but across the world. So many of our organizations learned new ways to organize people, and also went from, they are the API queer organization in Dallas, but they're also having people from Copenhagen and Bangladesh and Dubai chime in to their virtual events. And for some of those people, that was the first time they had been plugged into this specific kind of community. So I think this was one of the few opportunities. I am, like Monica said, there were a lot of things we didn't learn, and we are going to have to unpack some of that damage. So I really do love the fact that we were able to get more people into community and through access and the virtual stuff. But I also know within our organizations, within our groups, we've not had conversations about frontline workers as if they were not queer and trans as well. We've not had conversation about sex workers and how we basically did not give them the tools to make a living during the pandemic. So it continues issues around inequities and privilege in our communities. So yes, it is positive that we're able to organize more people and be virtual, but I really do want to dig into who was left out and what are we doing going forward. And finally, I hope one of the positive things that come out of this is an understanding that we are replicating certain patterns here of accessibility to medication, for example, in the United States, in the first world, and the global South is suffering the same way. It is we saw this with HIV medication, we saw this with PrEP, We've seen what Gilead has done, and we're seeing this again. And hopefully accessibility to life-saving drugs and vaccines is something we've learned to do better.
Great. Well, Monica, Debanuj, Kenrick, and Aparna, thank you so much for participating and answering these questions and providing some really interesting, important history, even some that I was not aware of. So I'm really grateful for your responses. I do want to provide a little bit of space and time for any of our attendees to ask any questions. So please feel free to either put some questions in the chat box, or if you want to raise your hand, I can call on you if you would like to ask your question directly to any of the panelists. I'll try and take at least one or two questions. So. Anyone? Bueller? Okay. Well, I think it sounds as if maybe everybody on all of the attendees learned a lot and they have no further questions because all of the questions were answered perfectly. So maybe what I'll do is I'll go back to one of the questions. Oh, actually, sorry, Dr. Abbas, go ahead. Amber. Oh, you can't hear me?
There
we
okay.
go.
I thought I couldn't unmute myself. I wanted to say thank you so much to all of the panelists. I learned an extraordinary amount. I started the session in my car, but I have since safely returned home. And also, I think one of the things that's resonating with me is the ways in which sort of the disconnection and grief of the past has really started to manifest itself in like these opportunities for solidarity building and community building. And I maybe this is more comment than question. I'm an academic, that's what we do. But just to say how inspiring it is to me to hear that perspective from you in all of the different spaces where you're working, and also to say to Nikhil how impressed and delighted I am by the way that your project is delving into this space that both illuminates the tragedies and the tensions that people within our communities have experienced as a result of this kind of double and now maybe triple stigmatization, and the ways in which there's been persistent activism that, from my perspective, has just been totally invisible until this very moment. And I just want to appreciate each of you so much for the diverse and extraordinary work that you continue to do, and to bring it to our attention. Thank you.
Go ahead, Shimon.
Oh, hey everybody. First of all, thank you, Nikhil. Thank you to all the panelists. Some of y'all heard about, and I'm so grateful to see y'all and hear from y'all today. Nikhil, this is probably a question for you and also the panelists, is that now seeing all the research you've done and everything, what is something that you would like to see from this 10 years from now?
That is a great question. I have not really done a lot of deep reflection because I've just been so mired in the data and in the stories of everybody. But I actually do want to sort of hark back to something that Amber just mentioned around sort of the invisible work of the activists. I think that's something that has come up over and over again, is that despite all of the challenges and all of the awful things that we're seeing in the world, at the end of the day, activists are the ones who are continuing to do the hard work. They're the reason that we're able to see any change. And specifically, I do want to highlight that South Asian Americans are part of those activist communities. I'm very grateful for my advisory board member, Radhika Balakrishnan, who is on this call today, who helped start South Asian AIDS Action. I apologize that her oral history is not ready for upload, but hopefully it will be soon. But she was the one who started the initial collection on SAADA, and actually that was actually how I found SAADA. So lots of sort of ripple effects from activists throughout time. But I've definitely had a lot of conversations with many of my interviewees, and I think the thing that we talk about the most is that activists were the reason that change happened in the AIDS epidemic, and but again, they remain invisible. And the same thing is happening today with COVID-19, where there are activist communities. I mean, we talk about ACT UP in the AIDS crisis. ACT UP is continuing to do work around COVID activism with a very similar model, but it doesn't seem to be getting sort of the same attention the way that we're reflectively thinking about the work that ACT UP did during the AIDS crisis. So I definitely, I think, to answer your question, Shimon, I think 10 years from now, I really want to make sure that we continue to center and value the voices of activists, particularly activists from vulnerable and marginalized communities, because at the end of the day, I mean, what is it, the quote from Margaret about it just takes one person to change the world. Or sorry, a community of thoughtful, dedicated people can change the world. And that continues to be true, that the only reason we're seeing change is because of people on the ground who care and want to make change in our world. So I hope that we continue to try and find more ways to spotlight, center, and continue, of course, to support the work of activists moving forward. So.
Nikhil, can I quickly also jump on that question? And
yes,
I think the work of SAADA and like Nikhil's project as an example is very important. I think 10 years from now, we don't want to be in a place where stories of COVID-19 within the South Asian community has not been archived, right? Because it is through storytelling, as Dr. Gandhi would, and any of the academics or scientists would sort of speak to this, it is listening to the stories that help us frame our academic questions or the research questions. And when there is no story, when there is no archive, we have erased that memory, right? We have erased our community's history. So I hope 10 years from now, there will be a rich archive, of this recording, of this moment, and another quick thing is I think that we continue to center pleasure and the body, like the rights over your mind body, in this work, right? I mean, one project we can look back to, I don't know if there's the archive, I saw Surabhi here earlier, was the SLAP project, which is Sexually Liberated Artists and Activists project that created amazing visuals that were erotic, but had HIV prevention message in it. So to go back to Monica's point about pleasure and COVID-19 and risk reduction, we could look at some of these models in our communities.
Great. And I did also just want to quickly answer a question that was in the chat from Anirvan, who served as a little bit of an informal advisor to me throughout this entire project. So Anirvan, thank you so much for helping me out with my original application and for being an incredible resource for me during this time. But he did ask sort of me to provide just a quick overview. So I was able to do oral history interviews with 17 people, which one of the interviews was actually with 2 people at the same time. So I have 16 oral histories. About half of them are uploaded to the SAADA website. Miriam, if you're able to drop that link into the chat box, that would be helpful. And I encourage you to go ahead and start listening to these interviews. They really are incredible. I mean, I obviously conducted the interview originally, and when I went back and re-listened to it, I found them to be just as incredibly inspiring, as incredibly poignant as they were when I first did the interview. And some of them are very, very long. I apologize. But again, these are oral histories. We want to be able to understand not just specific questions, but also sort of the context of how people got to specific places within sort of the AIDS epidemic. And I've tried to highlight different voices from men, from women, from gender nonconforming, from people who were activists, people who were healthcare workers, people who were service delivery providers, from the queer populations, people from the East Coast, West Coast, and Central and the middle of America, people who immigrated who traced their roots back to India, Pakistan, Bangladesh, the diaspora community in East Africa. So I really wanted to try and get sort of a diversity of voices to make sure that I was really elevating everybody. And this is a project that I'm planning to continue into the future. This is just the start of this work. As we move into the future, because again, this is a timely project. We're 40 years out from the from the beginning of the AIDS epidemic, and we're about to lose a generation of people who were there at the beginning. So I'm definitely continuing to move forward with collecting more artifacts and collecting more stories from people. One thing that I know that we're just a couple more minutes, but I did want to do a quick introduction that today is the launch of a new initiative that I have created that has come out as sort of a need from this project that I've identified. And that is that I've done a lot of work sort of looking for people of South Asian descent who were HIV positive and who died from AIDS. And I was having difficulty finding those names in the existing memorials, but as I spoke to people through the oral history interviews, I know that there are South Asian Americans who have died from HIV/AIDS. Their names and their stories and their memories are just not reflected in these memorials. And I wrote a Tides article that came out in May that sort of talks about sort of some of the reasons why their names were excluded. So I really wanted to find a way to change that. So today is the official launch of a project that I'm titling the SARI Project, South Asian Americans Remembering Individuals. And the SARI Project is a community-driven participatory digital AIDS memorial that was sort of inspired by the AIDS quilt. Miriam, if you're able to post the link to the website, if people can go there. Basically, I'm trying to collect stories of South Asian Americans who are no longer with us because of HIV/AIDS. I also want to highlight activists and other allies who were on the forefront and helping fight discrimination and stigma. I was able to put together a panel, a quilt of patchwork sari fabric, thanks to a wonderful artist that I was able to find. Her name is Kavya, and I hope that we'll continue to be able to work with her and help build out the quilt project. And I started off with one quilt of an activist from Canada. His name is Kalpesh Oza, and he was a very prominent AIDS activist who would have been known not just in Canadian networks, activist networks, but also American activist networks. So I was able to find some memorial information and some pictures. So his panel is represented in the memorial quilt. And I hope moving forward that if you have a story of someone that you would like to memorialize, that you can reach out to my project, so we can continue to build out this quilt and continue to ensure that we don't lose the memories and stories of people from our community moving into the future. And something that I think I asked everybody to do at the beginning was to, if you're able to have a candle and something to light it with, I would like to take the next minute of silence just to honor those that we lost. A lot of them are anonymous right now, but I hope that we're able to put a name and maybe even a picture to their name on the memorial. So if you're able to grab your candle, and I will go ahead and light mine. Great. And we'll go ahead and just take a moment of silence for our community. So. Thank you to everyone who was able to attend today's event. Before we end, I would like to thank a few specific people without whom today's event would not have been possible. First of all, I am indebted to my interviewees, and thank you to those who are in attendance today. To my interviewees who agreed to participate and share your stories. Thank you so much for opening up and sharing sometimes traumatic stories of loss and love. And I'm so grateful that I got a chance to be the person to ask you those questions, that I was the person who was able to collect those stories and put them into the archive. I'm forever grateful for your participation in my project, because without your stories, this project would not have been possible. Thank you to Samip, Miriam, and Nivetha at SAADA, who were able to put together this event and have helped me put together my exhibit. The exhibit is live now, and it's not complete. There are still lots of pieces that need to be done, but I'm hoping that over the next couple months, I'll be able to get a lot of these pieces up and running for you to be able to hear some of the stories and see some of the pictures. But there are some preliminary materials, so I definitely encourage you to visit, read, and listen to some of these stories. Thank you so much to the Andrew Mellon Foundation for funding this fellowship. As I mentioned earlier, thank you to Kavya, the artist who created the beautiful logo and the Sari patchwork panels. Thank you so much to my fellowship cohort, Dada Saheb, Efad, Nargis, Ome, and Savannah, for your fellowship and your friendship and your unconditional support throughout this entire grueling 9-month process. And lastly, but not leastly, thank you so much to my husband, Ryan, for putting up with my late nights and my very busy schedule. I love you very much. So I really appreciate everybody's interest in this topic, and I invite you to explore the exhibit over the coming months as it continues to grow. And if you have a story or memory to share about yourself or a loved one that you want documented and preserved in the archival collection, please don't hesitate to reach out. You can email me and SAADA directly at epidemics@saada.org. So epidemics, EPIDEMICS @SAADA, SAADA.org. So thank you, everyone. Have a wonderful rest of your weekend, and happy Pride Month.